Hi there. In this lecture, we're going to talk about controlled community trials. Most trials are conducted by allocating treatments or other interventions to individual research participants, patients or clients, or people participating in a prevention program. The treatment or the intervention is allocated at the individual level. In contrast, group trials allocate the intervention to groups of participants. These are mostly disease prevention or health promotion studies with whole communities, such as cities or states, serving as the unit of analysis. Again, not the individual. And the intervention is assigned to everybody in that community or in that group, like a school. One type of community trial that we're going to talk about is the cluster randomized controlled trial, in which groups of subjects, as again opposed to individuals, are randomized. Cluster randomization is a type of experiment in which the intact units or clusters of individuals are allocated to the intervention groups. Clusters can be geographical in terms of villages or communities. They can be administrative areas like zip codes. They can be social units like families or households. They can be educational or occupational groups like schools or classrooms. They can be hospitals or work sites. And they can be professional groups, for example, all students taught by a specific teacher who's delivering a new prevention program, or to patients who receive a special type of intervention from a clinician. Examples include medical practices that are selected as the randomization units in trials evaluating the efficacy of alcohol screening and brief intervention, or communities selected as the randomization unit in trials evaluating the effectiveness of a new community-based health care intervention to manage substance abuse in pregnant women, or hospitals selected as a randomization unit in trials evaluating guidelines directed at physicians or administrators to restrict the way that they prescribe opioid medications. In all of these cases, the unit is at the level of a group rather than individuals. And a key property is that this unit of randomization provides different challenges in terms of bias and data analysis than individual level studies. In the case of groups being assigned to one condition or another, there can be lack of independence among the individuals in the same cluster because they can influence each other through intra-cluster correlation. And this creates special methodological challenges that need to be handled statistically. And for that reason, often multiple clusters are included in a given cluster randomized trials. So you can look for variability across the clusters, even though they all receive the same intervention. At the cluster level, the fact that a classroom may have some very disruptive kids and another classroom may have some very cooperative kids might make for differences that are independent of the effectiveness of the program itself. The value of cluster randomization is that it provides administrative convenience. You can go in and you can train teachers to administer a program in a classroom, and you can collect data in another group of classrooms that don't have the intervention. It's easier sometimes to get cooperation to do the investigation from administrators. There are ethical considerations that sometimes prevent us from withholding interventions from individuals, which can be then promised to a group that serves as a control group. After the intervention is completed, the control group gets the intervention. There are a variety of other reasons to use these cluster randomized designs. There are at least 3 ways of doing these designs: completely randomization designs, matched pair designs, and stratified designs. Completely randomized designs look for the effectiveness of a program in a school or a community by evaluating the differences between groups that are randomly assigned to the program or not assigned to the program. And those 2 groups are compared. At a group level, it's similar to randomizing individuals to do 2 different interventions. A matched pair design doesn't involve randomization, but the selection of communities that are matched in all other respects. And in 1995, there was a major study of a community intervention that was designed to reduce the prevalence of cigarette smoking. And the unit of randomization was the community, and there were 11 matched pairs. And the pairs were matched in size, population density, and other characteristics, so they were comparable in all other respects other than receiving the COMET intervention or not. Finally, there's the stratified design. And an example would be a prenatal counseling program to reduce fetal alcohol spectrum disorders, which occur usually during the second trimester of prenatal development, where the mother's heavy drinking contributes to a variety of different morphological features and cognitive disabilities, which stay with the individual for the rest of their life. And in a stratified design, the unit of randomization is still at the clinic level. But what happens is, if you're doing a large-scale study, you want to take into account other factors which may influence the success of your intervention. So, for example, the World Health Organization typically studies groups in different countries. And even though randomization can occur at the level of clinics within a particular country, you also want to see if that effect holds over a variety of different countries. So in a study like this, you might want to evaluate the impact of an FASD counseling program, whether it was received or not in a clinic, in countries like Cuba and Saudi Arabia and Thailand, and in an English-speaking country. And if you get similar results across all of these regions, you are in a much better position to then recommend that program globally. What are the threats to the validity of these kinds of research designs? Well, selection bias in the recruitment of patients over time can occur, and experimental contamination. For example, consider a trial using a simple randomization scheme where practices in which physicians are asked to identify as well as treat selected patients for a substance use disorder are randomized to a program or a control condition. If the practice has been randomized and the physicians know that they're in an international study, they may pay much more attention to their patients with substance use disorders, far beyond what they would do under normal clinical practice circumstances. So the fact that it's often difficult to mask the intervention from the person who's delivering it may affect the way it's delivered. In your readings, you're going to come across a wide variety of examples this week from community prevention trials conducted in the Nordic countries, New Zealand, Australia, and the USA. These trials have evaluated the effects of mass media campaigns, college programs to combat binge drinking, studies of increased enforcement of drunk driving laws, and sometimes the intervention is developed within a community by a coalition of stakeholders and consumers and experts, and they put together an intervention. Regardless of whether it's pre-planned or it's developed by a community action group, the randomization of groups, whether it's communities or schools or other units of analysis, provides a basis for evaluating the effectiveness of different interventions, both at the individual level and at the population level. And the lesson, hopefully, that you're going to derive from our review of community-level intervention research is that this type of observational study can be a powerful way to evaluate the impact of planned interventions that are competitive with randomized clinical trials in drawing causal inferences about what works and what doesn't work.